There you go. Hi, everyone. Yes. All right. So can you guys confirm that's working?
Yeah, I'm
Can I have a look? Can you hear me?
I don't know if I can hear you. Yeah, you can try to. All right. Let's see. It's on YouTube. Yeah.
Sweet.
Yes.
All right. So hello again, everyone. So for everybody at home, my name is Taha. Welcome again to YESPA after a good long break. Well, it's not long enough, I guess. So this one down. Oh, good, it works. All right. So what we're going to do today is we're going to go through this paper. Oh, that reminds me. Get it out. So we're going to go through this paper now. I understand that it might not be the same for you guys. I think they might have changed the naming scheme, or maybe they've uploaded more papers. But if you go to the Y files and you go to resources and past and faculty release exams, is paper 6. So I'll give you guys a moment to open that. Otherwise, you can follow along on the screen. All right. Now, there might be a lot of technical hiccups because this is the first time I'm doing this, using the pen and stuff, but hopefully it works out for the best. All right. So we may as well get started. So, all right, have a read of this question and see what do you guys think. And just because there's a lot of questions and there's quite a lot of detail, I want to go in for a lot of things. Hey, Roland. Just please yell out your answer. Okay, don't be scared to. This is a safe environment. All right, we're trying to be productive. We're trying to be helpful. So, if you have a question, if you have a concern, if you have a suggestion, please just go ahead.
This is the one I wanted to ask.
Okay.
So, out of all the answers you can use now, it's recommended you use Indepth, although technically it doesn't really matter. So, is there anyone like, I guess, so I guess technically the answer is Indepth, but you can also give systemic pred, and systemic pred has actually almost equal efficacy, and they say also that it has less adverse acute effects. Yeah. So I'm a little bit like, I know that like the answer they want is Indepth release, but I'm sort of like between the two. I know that like that maybe more Indepth, but like, do you know what I mean?
I understand your suggestion. That's very true. So what Yasmin said is correct. Based on ETG, for acute settings of gout, you can use either NSAID, and if they're non-reactive to NSAID, first-line therapy is also injectable corticosteroid therapy. In this case, it might be prednisolone. It doesn't specify that this is oral, so it doesn't really matter. So there's a reason that they've put diabetic in this question, okay? So although using corticosteroids is not a direct contraindication to using steroids, it would be something that you need to think about. And the point of this is that you need to look at each question and understand why they've put in each piece of information. There's a few things that are important as we go through this whole exam. Okay, there's a few things that I want to highlight to you. The first one is reading all of the options that are there. Second one is reading everything at the top. You have to read exactly what they want for the question. And the third one is don't rely on your buzzword knowledge because it's not going to help you. All right, so the diabetes in this question would be a relative contraindication to using prednisolone, which is why it's not the best answer. So indomethacin is the best answer. So indomethacin is an NSAID, so that means it works non-selectively on COX-1 or COX-2. And the reason, there's no specific reason why it's better for gout. However, it does have an effect where it decreases, it causes inhibition of neutrophils. So it causes an decreased inflammatory effect, which is why it's more preferred than other NSAIDs for usage in acute gout. So in this question, it's correct he's already had an NSAID. It's correct he's already had Panadol, but indomethacin is really the best answer here. So, like I said, this is going to be an in-depth session. So we're not just going to go through the answers. We're going to try and revise as well, all right? So if we were looking at a pain ladder, what would be number 1? What is the number one medication that you'd use? Yep, okay, paracetamol. What else comes number one? Okay, we'll leave it at number one. Next one, next line. So if they're non-responsive to paracetamol, what's next? Okay, so what do I circle here? What else? What else? So NSAIDs is correct, but what else is second line? So if they're non-responsive to NSAIDs, you can also try. Yes, but what? Yes, weak one. So yes, codeine and tramadol. Why is codeine considered a weak opioid? Yeah, so it's converted to morphine inside of the body, okay? Similarly, tramadol is not exactly like codeine, but it is weak, all right? So then our third or last line therapy would be what? Which ones? Morphine, okay? So we have 3 morphines here, and that's going to be important soon. So that's 3, and then that one was 2. All right, 2. So you can understand. So this is another important way to look at the question, right? You can try and group the answers and see what they want. So we've got our classical pain ladder as options in this question, and then we've also got a fentanyl patch, we've got a buprenorphine patch, we've got pregabalin, we've got prednisolone. So we've talked about prednisolone and why it wouldn't be the answer for this question. Pregabalin, what's that used for? Neuropathic pain. Buprenorphine patch. So that's used for chronic, non-malignant pain, okay? So specifically non-malignant. And fentanyl patch is, I mean, rather than the patch, more like intranasal fentanyl would be another thing that you might use, especially in the pediatric setting. So intranasal fentanyl is just as, well, is in the same category as morphine in terms of strength. And that is something that you might consider in the pediatric population because you can do it through the nose. All right, so that's first question. So then moving on from that. Sorry? Yeah, so colchicine is second line. So it's not first line. The reason for that is colchicine has more adverse effects associated with it, and indomethacin has a similar efficacy as well. Okay? So second question. Now, like I said, I don't want to rush you guys, but the quicker that we are, the better today. So anyone yell out an answer?
H.
Yeah, H. Okay, what's her problem?
So she's in palliative care. She has metastatic pain,
Yeah.
bone and liver, which is not controlled by oral. But we can't give medication orally because she can't solve it.
Okay, that's exactly correct. So according to the WHO pain ladder, so there's a few pain ladders, especially the WHO pain ladder. They also start first of all, and this pain ladder is in relation to malignant pain. So first line is still your non-opioid medications, which would be your paracetamol and the such. Your second line is again your mild opioids, and we've talked about which ones those are in the previous question. And then your third line or your last line is your strong opioids. Now, why in this case is it particularly H rather than the other morphines?
With continuous because terminal cancer and the pain is.
Okay, so D brings up an important point. So when you're managing pain, especially in the palliative population, instead of managing the pain PRN, so as the patient requires it, it's more important that you have a background level of analgesia all the time. That is more effective in managing the pain than giving them pain medication only when they require it, which is why a syringe driver, which is what the subcutaneous infusion is relating to, is better than giving them a tablet. Although you can give them a tablet and still have a background level, a subcutaneous infusion is better. There's many reasons. All right.
So if she could swallow.
No, still a syringe driver. Syringe driver is still better. Because the other thing is that with somebody in palliative care, they likely also have GIT upset at the same time. So you don't want something that's going to aggravate that, and a syringe driver is going to increase the availability for morphine. So that's why a subcutaneous infusion is better. Worse. And I'm not sure if morphine is available in patch. Okay? I'm not sure. Okay. So yell out an answer. Suggest an answer. Why? So what's his issue? Not shingles. So so post-hepatic, okay? So this is a common presentation, especially in the elderly populations, is post-hepatic neuralgia. So this is when the HSV stays within that dermatome and it causes pain that that maintains after resolution of symptoms of the acute herpes. Acute shingles. So if the patient did have acute shingles, what medication would you give them? Yeah, true for the habit for the pain. Panadol, okay? So Panadol is still first line. Topical therapies, so things like lidocaine gels, lidocaine sprays, they haven't got the evidence behind them that they have efficacy. So paracetamol is still first line for the pain associated with acute herpes. All right.
You give them something like pre-government. Haven't they shown that hitting it hard early stops reduces the rate of post-herpetic development?
Yes, so for post-herpetic, yes, your pregabalins and any of your neuropathic medications is correct. But I'm talking about just for the acute herpes pain.
No, I mean, for the acute one, if you get it hard with pregabalin, apparently reduces the rate of post-herpetic development.
I'm not sure. Okay. All right. Anything else?
So they just said neuralgia like that, but what if you really weren't sure of the post-herpetic, you still use paracetamol?
I'm not sure yet. All right. All right, so moving on to the next question. All right. Now, another thing, I was giving this advice to someone else today. So again, you know how I always go on many tangents, but one of the best ways that you can revise for the exams this year, this is of course just my opinion, but is to use these faculty exams and study directly from them, okay? So that means looking at each of these options, researching each of them, and understanding what the MCQ stem would be for that option. Okay, that's very important. And I'll drive home that point later in another stem, and I'll give you a very clear example of why that is so important. Okay, but at the moment, just before we go into the question, let's talk about Baker cyst. What is a Baker cyst? Anyone? Okay, cool. So I'm going to draw the joint. So what bone's at the top? What's this? Femur. And what's at the bottom? Tibia. Okay, and what's here at the front? Patella. Okay, now where should I draw the bursa? So where are the bursas located?
Is the suprapatellar?
So yeah, sure, that's correct. How about within the joint itself? So there's one here, right? So there's fat pads and everything, but there's also a bursa here. So what would this one be called? Pre-patella. So this is the pre-patella bursa, so it's coming before the patella. And what is this implicated in, this bursa?
Like which condition?
Yeah. Yes, and what's another name for that? Yeah, housemaid's knee. Okay, that's good. All right. So how should I draw Baker cyst? So it says cyst. So the word is cyst, right? So Baker cyst is another name for a popliteal cyst. Okay. So you have the synovial cavity. I'll draw that in a different color. So your synovial cavity is in here, right? Filled with synovial fluid. So a Baker cyst is when you have a connection into the back of the knee, into the popliteal fossa, and that causes a popliteal cyst. So you have synovial fluid that goes into that, and that causes pain, that causes warmth, and that causes all of your symptoms of a Baker cyst. So that's just important to know. So a few other things on this list. What is chondromalacia? Where should I draw the pathology? So chondromalacia patellae. Yes, perfect. So that is inflammation of the cartilage that is directly behind the patella. So this condition is usually implicated in young athletes. So for example, a skateboarder, one of their feet is always off the skateboard, pushing them forward. So they are likely, or they are a population that often gets chondromalacia patellae, and they will present just in pain. What's chondrocalcinosis? Yes, calcification. What is it secondary to usually? So this is usually secondary to CPPD. What is CPPD? Pseudogat. Okay. So pseudogat or arthritis, the two common causes that can cause calcification of your cartilage. So that is something that's often asymptomatic and usually just picked up on something like an X-ray or some kind of imaging. All right. So so for this first question, What do you think she has? So she has a twisting injury, right? Intermittent sharp pain over the medial aspect of her knee, effusion, joint line tenderness, and pain on forced flexion. Now, what gives this away is the last sentence, forced flexion of the knee. What test do we do forced flexion of the knee? McMurray's, okay. And what's McMurray's testing for? So what does she have? A meniscal tear, but which meniscus? There's two. Medial, right? So she has a medial meniscal tear. Everything in this question suggests that. The fact that she has medial pain, the fact that she has joint line tenderness, okay, within the joint, and forced flexion of the knee. How do we do, can somebody describe how we do a McMurray's? Okay, so we start with the leg in this position, right? Which is inflection, okay? Then we rotate it to try and loosen all of the ligaments in that joint. Then we apply a varus force. So I'll pretend the leg was there. So this is a varus force. And then we extend the leg, and that causes pain. So let's pretend that this is the medial aspect. So when you extend the leg in that position, that traps the menisci between the tibia and the femur, and that causes pain. So that's McMurray's. So that's what this stem is describing. The fact that she has a medial meniscal tear, the fact that she's had a rotation injury is also a classical mechanism.
This is forced flexion. Does that mean a drawer test?
So the anterior drawer test is more applying anterior force rather than the flexion force. But the thing is that when you force flexion, you're also still decreasing the size of that joint space. So that also causes pain. All right. Yes? Oops. Okay. So the carpal, so he's going to have the prepatellar bursitis like we talked about. Yeah, so the prepatellar region. So that gets inflamed. All right. L. Okay. And then this one was J. All right. So then this question. What do you think this man has? Okay, so if I was to draw this for you, this is a little bit how this man might look like. Just I've drawn that leg way too long. All right, so pretend that's his knee, and I'll draw his leg sort of like that. Okay, so it's not straight, so that's called posterior sag. So it's especially apparent when you're looking at the leg from the side. So what ligament is damaged? Yes, PCL. Okay, so this is so posterior sag is equal to a posterior cruciate ligament tear. Okay, so posterior cruciate. So what special tests, if we were to do an OSCE, do we do for the knee? So break it up into groups. So we have cruciate tests, we have collateral tests, and we have meniscal tests. Okay, what comes into each? So cruciate, how do we test a cruciate? We have two cruciate, we have the anterior and we have the posterior. Anterior is what? And what else? And Lockman's, okay? So Lockman's is more commonly used in the drawer test, and the posterior one is the posterior drawer test. So do you guys remember how to do the drawer test? So you have the patient's knee flex, and you either put anterior force or posterior force. The other thing is that when you look at the patient's knee from the side, you will notice an evident sag. So that's resulting from posterior cruciate. Remember, posterior cruciate is at the back of the knee joint. All right, collateral ligaments. Yeah, varus valgus. And then meniscus. McMurray's. Perfect.
So which one goes like back to front?
So it's usually the location on the tibia that indicates whether it's anterior or posterior. So anterior cruciate starts, so it starts at the back of the femur and goes to the posterior tibia. All right. All right. So what do you guys think for this question? All right, so we have 71-year-old, so he's very old. 4 to 5 days of severe right-sided throbbing headache, loss of vision in his right eye. Okay, what is he likely got the throbbing headache from? Okay, why has he lost his vision? Does anybody know what the diagnosis is? Temporal arteritis. Okay, so he has temporal arteritis. There's nothing else in this. I mean, I would like to go through all of these options, but I can't today. But temporal arteritis is the only one that fits. He has right-sided throbbing because what is throbbing? His temporal artery. Okay, and why has he lost his vision? What's this called? Why?
Like, is occlusion of the retinal?
Yes. Okay. So retinal artery. All right. Next question. What do you think this lady has had? Oh, right. So we have a young woman, right? Severe throbbing left-sided. So that's your first indication. Is unilateral. Frontotemporal. So it's coming in a very evident location. So if we were to draw this lady's head, all right. So just one side. Okay. Nausea and vomiting. Intolerant of light. Now, what diagnoses cause photophobia? So this is photophobia. Yes, what else? And? Yeah. Okay. So migraine, SAH, and meningitis. So do you think she has one of these three? Does she have SAH? Why not? Yes, she's young. Okay. So her age. Does she have meningitis? What do you need? You need fever. Okay. So therefore, what does she have? Okay. What are you going to do for her? How are you going to manage her? Okay, dark. What else? Sleep. What else? Fluids. What else? Panadol. As well as Panadol, what are you going to give her? No, you're not going to give her triptan. It's too expensive. What else? I mean, oxygen is correct, but oxygen is usually reserved for very severe cases. So that's called what's it called? Can't remember the word. Rescue therapy. That's called rescue therapy. So you don't typically use oxygen. But what else do you give her? Panadol and what's better than Panadol? NSAIDs. Okay, good. Now, what type of NSAID are you going to give her? What's a simple NSAID you can give someone? No, aspirin. Okay. What type of aspirin are you going to give her? Are you going to give her oral? Are you going to give her subcutaneous? Are you going to give her intramuscular? No. You're going to give her subcutaneous, okay? Or a buccal. So you're going to give her buccal aspirin, which is called Disprin. The reason for that is people with migraine often present at the same time with GIT upset. So if you give them an NSAID at the same time, that can cause further GIT discomfort or worsening their symptoms. So Disprin is something that you can put under the tongue and that's absorbed through the oral mucosa. So that's something that you can give instead. All right. All right. And I guess, so you mentioned triptans. So triptans are a gold standard therapy. However, they're very expensive, so you don't routinely give it to someone unless they're having like chronic headaches. That I think might be one of the PBS subsidiaries. All right, good. All right, what do you think this lady has? So 40, sudden onset. So there's not many things that are acute, okay? Now, before we go on, so headache. What causes an acute headache? What else? We just had one in the previous question. Migraine. Maybe not temporal arteritis. Meningitis. What else? Look, we've got our same list again. Okay. Yes. Good. Glaucoma. Trauma. So there's a long list. So it's a good way to think about it. She has neck stiffness, okay, which would then coincide again with SAH or meningitis, confusion and vomiting, which doesn't rule out either diagnosis. Her complaining of a lesser episode, which occurred 3 weeks prior to today's presentation. So what does that mean? What's more likely happening here then? SAH. Why SAH? What do we call this? A sentinel bleed. Okay, what is a sentinel bleed? It's not necessarily a microbleed. It's an SAH that hasn't been clinically picked up or didn't present clinically or the patient didn't notice or something of that nature. So given her age, why do you think she's had an SAH? What's subarachnoid usually secondary to? I mean, all of this is correct, okay? But in general, subarachnoid hemorrhage, you're having an aneurysm, a berry aneurysm, is less likely to be a congenital. It's more likely to happen just because of your comorbid risk factors. But in her case, given her age, yeah, maybe that's a potential. Maybe it was congenital, maybe it wasn't. But the answer I was trying to get is the fact that you have a berry aneurysm. Oh.
Try this a little more.
Okay, you have an aneurysm that then bleeds. Okay, good. Now, let's look at the next page. Oh no, it's not there. Oh, dang it. Okay, if you were to look at a CT scan, where would the bleed be? Where would you see the hyperattenuation on the image? Yeah, the basal systems, because that's where it's bleeding into. So CT is something that you should be doing within the first 12 hours. After 12 hours of symptoms, what are tests you can do to confirm your diagnosis? What are you going to see on the lumbar puncture? Yes. What is xanthochromia? Yes, bilirubin. Okay, xanthochromia. Because remember, bilirubin is a breakdown of blood cells, so that's not incorrect. Xanthochromia. I'll leave that there. All right. So if I was to draw a picture of a brain, all right. So if I was to draw the picture of the brain, you would see blood somewhere in here in the side of the basal systems if it's an SAH. If the blood was here in sort of this shape, what would it be? Yeah. Okay. And if it was going around the brain like that, what would it be? Subdural, and this is the extradural. Okay. So tell me some quick information about each. Extradural is usually secondary to what? What type? Injury. Okay. Damage to which artery? Middle meningeal. And subdural, what is the patient population who gets these? Elderly or alcoholics. Why?
Brain extra.
Okay. Why is that important? Why is it Yes. Okay. Right. So cerebral atrophy. So a subdural is due to rupture of the bridging veins, right, that are in the subarachnoid space. Sorry, within the subdural space. So having cerebral atrophy increases that distance, and therefore it increases the space that your brain can move around. So if you have a trauma, it increases the propensity for those vessels to bleed. So elderly and alcoholics. All right. So which space is the CSF in? Subarachnoid. Okay, good. So I don't need to draw that picture. Oh, I don't know if I'll be able to explain these questions. So we have a young man. He's coming back on a holiday, Southeast Asia. He used some substances intravenously. So he's got a lot of risk factors, upper abdominal discomfort. So he likely has hepatitis. So he has anti-HAV IgM. So first of all, which one's acute? So IgM or IgG? Okay, so this one's acute. So it's negative. So does he have an acute infection? No. So we can rule out that, probably a lot of the other ones. Anti-HAV IgG positive. So what does that mean? So he's either been infected before or he's been vaccinated. And which one was it? Anti-HAV. So against Hep A. So we know that information. So which one of these says that? So that one potentially, we'll keep going. HB Psych negative, what does that mean?
Not currently.
Okay. So this is the surface antigen of hepatitis B. So he doesn't have any hepatitis B currently floating around in his system. Okay. Anti-HBs positive, what's this?
He's been previously exposed to it,
Mm-hmm.
either for vaccination or he had it in.
Good. And what's this? HB core.
If you have it, it's positive. If you're vaccinated,
Yeah, so again, this is acute, so he doesn't have an acute infection, he doesn't have HCV. So this corresponds therefore to this. So he's had hepatitis A in the past, as we found out, because he had IgG. He has been exposed to hepatitis B, and we don't know what it is. And he doesn't have hepatitis C. Okay, does that make sense? All right, next one. So this one, we have a 32-year-old woman, recently arrived in Australia. She went to the Middle East. She doesn't have a record available. So anti-HIV, IgM negative, okay? So again, IgM, IgG. So does she have an acute infection? Negative. So she doesn't have an acute infection. Anti-HIV, IgG negative. So what does that mean? So she's not vaccinated, or she hasn't had an infection with Hep A before. So it's not acute, and she hasn't got a Hep A exposure. Okay, HB Psych positive, what does that mean? Okay, so she has something to do with Hep B. HBS negative, so she hasn't got antibodies, and she hasn't got the core antigen. So what does that mean? It's not an infection. Okay, so it's not an infection. So that means that she has probably had what? She's a carrier. Okay, so she's a carrier. So core antigen would indicate to you that she's infected because it's the core. Usually the hepatitis B within your body, it releases its surface shell, its lipid outer layer, which is your surface antigen, which she doesn't have. So she doesn't have an acute infection. But your core antigen can stay within your body for a long time. So she can still be a carrier, but not having an acute infection. All right. Then the last one. Well, okay. Well, no, she doesn't have an infection because she's not having an inflammatory response to the hepatitis. All right. Then this one. So we have 25. She's been unwell, right upper quadrant, abdominal pain, unprotected intercourse, multiple partners, mild jaundice, tender hepatomegaly. So she likely has hepatitis. All right. So again, IgM, IgG. So IgM positive. What does that mean? So she's got Hep A acute. All right. IgG negative. What does that mean? Yes, no vaccination. Okay. Surface antigen negative. What does that mean? So to either Hep A or Hep B, or at the very least, she doesn't have an acute infection. Okay, sorry, what am I saying? So she hasn't got an infection, but she's had the Hep B vaccine. Okay, so she's had a Hep B vaccine. And she hasn't got hepatitis B. So this response corresponds to, there you go, J. All right. Does that make sense? So that's an easy way to go through it. You just need to remember that IgM is acute, IgG is chronic. Okay. All right. So this is like with the I stem and with this stem, I didn't go through much detail. So this is something that I recommend you to go through in more detail. All right. So we have 50-year-old man, increasing deafness in his right ear. What does that tell you first? What is important about the fact that they only specify right ear? Is unilateral, okay? Unilateral. Not many things that are not pathological are unilateral, okay? You've noticed tinnitus. What other things can give you tinnitus? So noise-induced hearing loss, what else?
Unilateral.
Just tinnitus in general. Yes, so some things that cause vertigo, what else? Yeah. Anything else? Think non-ENT. So psychosis, okay? Psychosis is another thing that can cause tinnitus. Okay. So both tympanic membranes look normal, and the WYESPA test confirms right-sided hearing loss.
Wait, sorry, when you say psychosis, do you mean like while they're psychotic, or do you mean like the effects
Typically,
on the brain after?
No, typically during a psychotic episode.
Do you know if it's pure tinnitus or if it's a delusion?
Typically delusional.
Ooh.
Okay. All right. So air conduction. So RINA is positive, so it's not a conductory defect. and Weber is lateralizes, which means he has a sensory neural hearing loss. So it's sensory neural. So that's not sensory neural. That isn't. Both of these would be conductive. Unsure, but it's definitely not congenital because he's only just presented. Drug-related, potentially, but the stem doesn't have anything relating to drugs. It's not conductive. It's not conductive. It doesn't have vertigo. We've established that it's unlikely to be noise-induced because it's unilateral. Otosclerosis would be conductive. Presbycusis is unilateral. Sudden, potentially, but there's nothing in the stems to suggest that. Therefore, the answer is acoustic neuroma. Like this. So this is presbycusis. So this is just presbycusis is just age related. Okay.
Is this the 4 kilohertz?
So I mean, what's more important is that this audiogram is showing a gradual decline across all of the higher frequencies, which is what you expect with presbycusis. If it was another pathology, you might expect maybe like a spike there or a spike in some other random location, but this is a pretty linear progression. There's information in the slides if you want to read that. Okay, now these next questions are very important. All right. Does anybody want to suggest an answer? Actually, before that, we need to talk about, so I'm going to exit that quickly. Keep. Okay. So what we need to talk about now is we need to talk about palliative care, because that's a very big topic in GP, and in relation, all right, and in relation to, where did we go? So pal care, and in relation to pal care, nausea plus vomiting, nausea plus vomiting. So in palliative care, nausea and vomiting can be due to many different things. All right. So what are common pathologies that cause somebody who's palliative to have nausea and or vomiting? Okay, so drug-induced is correct. So what does the drug do that causes you to feel nauseous and or vomiting? What does it affect in your body?
Do you mean like the brain?
Yes, okay. So that's what I'm trying to get at. So it's a central cause, okay? So you can have central causes. So that's one, okay? You can have nausea and vomiting due to poor gastric emptying, okay? That's another one, gastric emptying. All right. You can have it due to hyperacidity. You can have it due to constipation. All right. You can have it due to a vestibular problem. All right. You can have it due to an intracranial pathology. So, for example, METS, intracranial. Or you can have it due to a bowel obstruction. Bowel obstruction. Or you can have it due to chemotherapy. So, how many is that? 1, 2, 3, 4, 8. So these are your 8 most common causes of a palliative patient to feel nauseous or to have vomiting. The reason I've broken that down like this is because your first line therapy is different for each one. And this is where I wanted to highlight that point before. So when I was telling you to use these exams as a way to revise, I don't know why I didn't do this last year, but all of these options came up on my exam last year, on our GP exam, but they were different stems. So the answers were different. But for some reason, I didn't revise all of these options. And if I had, I would have got those questions correct. So that's why it's very important to use these faculty exams as a way to help you to revise. Because what you do in this situation is you'd go to ETG and you'd read the article on palliative care and nausea and vomiting in palliative care, and you'd have that knowledge to back you up. So what I mean by that, you look at each of these options and then you try to understand in which scenarios would that be first line. And that would have helped you to answer the question. So a central cause. So central causes. So we've talked about one. So we've talked about drugs. So for example, opioids. They can be due to metabolic issues. So often people with palliative care, they can have hypercalcemia, they can have uremia, and this is just secondary to the drugs that they use, okay? And what all of these do, so especially the drugs, they affect the trigger receptor zone inside of your brainstem, and that's what causes the vomiting. So in this case, does anybody know what the first line therapy is? It's haloperidol. Okay, so if the cause of nausea vomiting is central, then the first line is haloperidol or metoclopramide. Okay, and then your second line is prochlorperazine. I won't write the whole thing. All right. So next one, if you have decreased gastric emptying, what you need is you need a prokinetic agent. So if you have things within your stomach, if you have things within your gastrointestinal system that are not emptying, that are just staying there, then you need something that's going to help that to mobilize. So you use a prokinetic agent. Does anybody know what a prokinetic agent is? An example? No. So lactulose would be an example of a laxative, right? These are things that work on, especially typically your dopamine receptors or something within your myenteric plexus to try and increase the peristalsis, the normal physiological peristalsis of your gut, to try and get that content to move. So in this case, it'd be metoclopramide, okay, or domperidone. Okay, by the way, guys, just if you didn't notice that there might be more than one number of first line therapy. So 1 and 1. So 1 and 1 is first line, 2 is second line, 3 is third line, for example. Okay, all right. So if you have hyperacidity, you can imagine what you would want to use. Anyone? Yes, PPI. And if we can't use PPI, then we use? Yes, H2 receptor antagonist. All right, perfect. Now, if it was due to constipation, what would we use? Again, the metoclopramide. Okay. Or the second line is haloperidol. Haloperidol. All right. Now, if it's a vestibular issue, you might not know this, but prochlorperazine. Okay. Now, with somebody that presents with nausea and vomiting in their palliative population with a vestibular defect, so vertigo or something of that nature, in a normal person, the answer would likely be something like BPPV or Meniere's disease, or maybe drug-related. But in the palliative population, rather than one of those diagnoses, it's more likely that they have metastases into their otic elements. So that's the more likely cause in the palliative population, and in which case we'd use prochlorperazine. If it was an intracranial issue, you guys should know this one. Yes, Dex. And dexamethasone also has another indication, and that is for refractory nausea. Okay, so if their nausea is not working with any of these other medications for any of these presentations, then we'd also give dexamethasone. All right, and okay, now this one is really important. So this is what came up on my exam last year. However, in that case, it might have been pain or it might have been constipation. It wasn't nausea and vomiting. But what's important is that these two which one? So these medications. Does anybody know why I'm highlighting these? Exactly. Exactly, okay. So these are completely contraindicated if the patient has a bowel obstruction, which is not something that's uncommon in the palliative population. You guys need to make sure that when you're thinking about things, you don't think in just one line of thinking. A bowel obstruction is presents on a continuum, right? Not all of them are going to be an emergent situation that needs to go to the ED and an emergency department straight away. You can have a bowel obstruction regardless. So in those situations, because metoclopramide is a prokinetic agent, and if you're obstructed up there, this would then push further content into that area that's already obstructed, causing further dilation. So metoclopramide or domperidone, which are prokinetic agents, are completely contraindicated if the patient has constipation. In that case, do you know what you'd use? Oh, sorry, if the patient has bowel obstruction.
You mean that not like due to constipation or like an actual
bowel obstruction. So what I just said is that bowel obstruction can present on a continuum, right? So bowel obstruction could be due to many things. It could be due to strictures, it could be due to metastases, it could be due to a tumor, it could be due to a drug side effect. But in any of these cases, giving a prokinetic agent, which is then going to push against that obstruction, is going to cause further dilation, therefore it's contraindicated. So in this case, if somebody has bowel obstruction and they have pain, you would give them haloperidol. Okay. So in my exam last year, I think he was he might have been asking about he was either asking about pain or either asking about constipation, something along those lines. So in that case, and this is really one of the only indications for this medication is hyoscine. So that's why it's on the list here. So hyoscine. So hyoscine is used for patients who have bowel obstruction, and it decreases the stomach cramps that are associated with that. And that is really only one of the only clinical indications for using hyoscine. A palliative patient that has a bowel obstruction to decrease the stomach cramps. So that's why it's so important to go through these exams and use that as a way to revise. So chemotherapy, you guys know, is ondansetron. Ondansetron. All right.
For bowel obstruction, like we're talking about meds here, right? For palliative, that would.
It could be due to many causes, but meds is something that you definitely want to think about.
Could you use Dex then to reduce, like, allow it to pass?
I'm not sure. I don't know. I'm not sure, to be honest. Okay. All right. So, okay, and if there were, okay, so that's nausea and vomiting, all right? Now, how about if the patient had diarrhea? So instead of nausea and vomiting, now we're going to move on to diarrhea. Do you know what medication we'd use? Do you know what medication we'd use? Loperamide, okay? So does anybody know what loperamide does? So loperamide is a dopamine antagonist. So if you remember the myenteric plexus that is present within our GIT, that is dependent on dopamine. So if we antagonize the dopamine, then we're going to decrease the activity of the GIT and allow some of that fluid to reabsorb and resolve the diarrhea. So loperamide. However, there is one caveat. I should put number 1 there. In that, in some cases, we use psyllium husk, and this was an answer to one of our exam questions last year as well. So psyllium husk is used specifically in cases of high output diarrhea. Okay, so high output diarrhea can happen particularly in carcinoid syndrome. So carcinoid syndrome is something that causes high output diarrhea. And the reason you give psyllium husk is because psyllium husk is a powder which absorbs a lot of liquid, which is why I believe you use psyllium husk. All right, so that's that. So
the diarrhea, so analyzing and then my exercise is also documented.
say again, sorry. Maybe I got it wrong. You should look it up. I think I might have forgotten them. All right.
So that's even in the case of like gastroenteritis.
What's the question?
Because normally, in normal adult medicine, gastroenteritis, you wouldn't give loperamide.
So this is specific for the palliative population. Yep. Okay. So I still haven't been able to figure out what chlorpromazine is in this list for. Okay. DEXA we've talked about is due to intracranial mets or refractory. Okay. So these are all the first line indications. Domperidone is your second line. Is your second line for nausea due to constipation. Haloperidol is your first line for which one? Yes, bowel obstruction. Hyoscine is for cramps, secondary to obstruction. Lorazepam, I'm also not sure why that's in the list. Metoclopramide, the decreased gastric emptying. Okay. Ondansetron if they're using chemotherapy, chlorperazine if there's a vestibular, and this would be second line for vestibular defects as well. So, all right, okay. So, lorazepam, does anybody know why that's in the list?
Anxiety.
Yes, anxiety, okay. So for patients that have anxiety, especially having anticipatory nausea, in that case, you'd use lorazepam, which is a benzodiazepine. So this patient is feeling, so she has, is really in the question, is anticipatory nausea. So she's already feeling nauseous before she actually comes to the chemotherapy unit. So you need something to calm her nerves down. And in this case, that is a clear indication for using lorazepam, which is, to my knowledge, a short-acting benzodiazepine. Okay, did we miss one there? Okay, all right. Say again?
Like, by his questions, If it was a central cause, would you pick haloperidol or
So, well, it depends on what the stem suggests. So haloperidol can have a lot of side effects. So in that case, it's more likely to pick metoclopramide, but maybe the stem might have contraindication for using metoclopramide. So it really depends on what the stem says. Okay, so this lady is on chemotherapy. So therefore, what are we going to use? On dance, which is H. Again, I don't know. Yes, but yeah, I don't know how these medications work, but prochlorperazine is an especially important medication because that's also first line for something else. Does anybody know? Hyperemesis gravidarum. So people know what that condition is? So if you look on the prompt guidelines, prochlorperazine is one of your first line antiemetics for a lady presenting with that. All right. What does this man have? Okay, so he has cerebral mets, so therefore Dex. Okay, perfect. All right. So you can see for this question, I ran out of time. I was going to make a stem for each of them, but I did not get enough time. But so neck and jaw pain makes you think what? AMI. Okay. So AMI. So what are the complications with an AMI? Sure. Death due to what? Yes. So asystole. What else? What else? Oh, did you say rupture? Okay, VT, whatever. And pulseless electrical activity, these things that can cause you to die. If the patient had VF or VT and they weren't responsive to cardioversion, what would you do? Yes, what would you use? Okay, and if the amiodarone didn't work? Adrenaline usually. Okay, all right. Okay, so I'm just going to write this here for you guys to remember. Look up the acute and look up the chronic complications. Okay, it's very important. No, it should be intramuscular, but I'm not sure. I'm not sure about a lot of these things. Okay, we won't do that then. Okay. Why did I put this in here? Okay, so there's a specific reason I put this in here. All right, so what does this baby have? Okay, you guys need to give me a list of differentials. So just describe, what do you see? What do you see here? No, you don't. Okay, there might be, but that might just be secondary to what the lighting is. But what is the most evident abnormality? How do you know it's non-blanching? Oh, you just look at the picture.
A rash.
What type of rash? No, petechial rash, right? Okay.
But isn't it sort of like MAs?
Sorry?
Like, I wouldn't say they're all like small petechiae. Like, there's some big blotches.
There are some big blotches, but what's most prominent is the petechiae. Like, you have multiple dots everywhere. So this is more predominantly a petechial rash. All right. So why do people get petechial rashes? But as in, what's the underlying pathophys? Yes, okay. So intradermal. So blood that's leaking into the dermis from capillaries, so capillary leakage. That's why vasculitis causes it. All right. So what specifically is a petechiae? What's the definition? Yes, pinprick, less than what size? So generally less than 3 millimeters. I mean, the definition changes, but that's usually, you know, some people say 3 to 5. It doesn't matter. They have to be small. Okay. And what's a purpura? Yeah, so I'll just write greater than 5. All right. All right. So you guys told me meningococcal as one cause of a petechial rash, but there are many causes of a petechial rash. What are others? So we can use our surgical sieve to break it down. So infection is one. What are other broad categories? Mechanical is another cause. Okay, you guys have told me vascular. So we'll start with these three. All right, so infection, what comes under there? Anyone? So we said meningitis. Yeah, meningococcal. Right there. What else? So strep is another one. Anything else? So just a common viral illness can cause a petechial rash. Now this is important. So we'll keep going. So mechanical. So we've talked about that a petechiae is due to intradermal capillary leakage. So just causing increased pressure just from coughing or having a fit can also cause petechiae. Obviously, well, unlikely to cause, this kind of distribution, large distribution, but it can cause it. So mechanical, we can put coughing. Okay. All right, another category. I'm going to make this one vascular/heme. Okay. Anyone can give me some vascular/heme causes? What was it? Yep. Good. So decreased platelets. Oh, no. That's one. What else? So what's also related to platelets? Yes, ITP. Okay. What else? What's to have a vascular cause? What's a vascular cause? A common vascular cause that could cause a petechial rash. Also presents with abdominal pain. Yes, HSP. Okay. All right. So with this baby, and there's always a reason I'm going to tell you things, and I'll tell you the reason after I ask you the question. But let's say you're in an OSCE and they ask you, how likely is it that this baby has a serious bacterial infection? What is the question I'm trying to ask? I'm trying to ask you, does this baby have meningococcal? What do you think? Is it likely or unlikely? Just looking at the picture. So in questions where you have no further information, what you should be relying on then is your epidemiological evidence. How likely is it for a baby in Australia to have meningococcal meningitis? Very low. So in most cases, a baby presenting like this is more likely to have an undifferentiated viral illness. However, because they are presenting to ED, it is very important that you do check for meningococcal meningitis. I'm not telling you not to check for it, but you guys need to move away from buzzwords into proper clinical practice. And you might not think that exams are based on the clinical practice, but often they are. So often they are based on what the evidence says. So meningococcal meningitis is not always the best answer. Okay. All right. Now there was a specific reason I was going to ask why I had this picture. So if this patient presented with his petechial rash in just a glove and stocking distribution, what do you think then is the most likely causative organism? So I'll give you a clue. So this organism also causes stridor. It causes a cough. It causes a toxic-looking baby that has increased work of breathing. No. So no, it's very common in your sort of less than 1 year age. So croup, right? Parvovirus. So parvovirus is an infection that can give you a rash in a glove and stocking petechial manner. So your classical presentation is your slapped cheek, right? But more common, or I don't know if it's more common, but another very way that it presents is by having this petechial rash in a glove and stocking distribution. So having parvovirus doesn't necessarily mean that you're going to get croup, but having a parvoviral infection can cause this dermal outbreak in this glove and stocking distribution. All right. All right. Sorry?
Most common.
Yes. But what I'm saying is that just like you can have a strep infection and not have pneumonia, right? You can have a parvoviral infection and not have croup. So croup is the causative organism for croup is parvovirus. But yeah. What did I say? Oh. Is parainfluenza croup?
Yeah.
My bad. Sorry, I was thinking about the wrong thing the whole time.
All right, let's do it again on the top.
But we'll keep it there. Parvovirus. Yeah, so I was thinking about the wrong thing. So parvovirus causing slapped cheek, right? Another way that it can present is with this glove and stocking distribution. Sorry for everyone at home. Get I confused? Okay. All right. I'm just going to tell you, just for the sake of time, I'll tell you what's happening here. So we have this patient, they have an acidemia, okay? They have lethargy, generalized malaise, and they look confused. In a young man, what is the diagnosis? Yes, DKA, correct, okay? So that's something that you definitely need to look for. So that's why when you're looking at an unwell patient, you always do your doctor's A, B, C, D, and then EFG. I don't know what E is, but it must be N. So or like D, don't forget glucose. Maybe, yeah, the A, B, C, D. Pretend E is not there, D, F, G. Oh, don't ever forget glucose. Yeah, so don't ever forget glucose. Okay, now back to our proper questions. Okay. All right, so this man, he was well prior to his injection. He went pale, and he collapsed, and he had a few tonic-clonic contractions. What do you think is going on? Yeah, so this is just a vasovagal. There's nothing too much to talk about here. And this last one. So she has a non-blanching rash on her lower limbs and trunk. And she has decreased GCS. So she has? Yeah, so she has sepsis. So anybody with decreased, so ACS stands for altered conscious states in my books. If they have fever, if they have increased respiratory rate or increased heart rate, all right, then fulfilling any two of these three criteria is an indication for further sepsis workup, okay? Not in that age group. Potential, but like the fact that she has changing GCS makes it much more unlikely that she has TTP rather than sepsis. I'm not sure it can, but I don't think it's a more likely answer. All right. Because you only need two of the three. But fever makes it much, much more likely. Okay? All right. Next question. All right. So, young lady, she has acne, and she wants to get some contraception. She has PCOS, so therefore, what are you going to give her? Why are you going to give her Diane? Okay, so the cyproterone, so this is an anti-androgen, okay? And she's presenting with androgenic disease. She has PCOS, she has acne, she probably has hirsutism as well, who knows? So giving her the cyproterone will prevent those androgenic features, which is why we give her Diane rather than any of the other medications. All right, how about this one? So what we have an immigrant, so she likely doesn't have perfect English or something of that nature. She has a very young child, so she might still be breastfeeding. She wants contraception. Okay, well, there you go. She is illiterate. She has problems following instructions. So she's willing to come back to your clinic for regular follow-up, which is very important. She had an ectopic 3 years ago. So what contraception are you going to give her? We'll just go through. Are you going to ligate her? No, she can't follow instructions. Can't follow instructions again. Can't follow instructions. So we can rule out all of these. Are you going to give, so we can't give her that. So therefore, our options come down to these two. So which one would you choose? Why? Okay, so that logic, I can understand your logic, but that logic is flawed. So an ectopic, so for patients who are on an IUD and then go on to have a pregnancy, which is like a 0.something% chance, then 50% of that is an ectopic if you have an IUD. If you have just normal COCP, then the chance is 10%. But having a Mirena decreases your chance of getting pregnant in the first place by quite a lot. So that is not the correct logic to have in this question. The better reason for not giving her Mirena is one, that she's an immigrant, okay? So you don't know if she has Medicare, you don't know if she has PBS. Second thing is she's illiterate, so you have to question whether she'll be able to consent to an insertion of a Mirena. Third thing is you don't know if she'll be able to care for it and come back to you if she has problems. So there's many other problems here for an invasive procedure rather than giving her a depot. So a depot is a better option because she's willing to come back to you. You only have to give a depot every 12 weeks. It's relatively safe, relatively cheap. So a depot is a better option in this case than having a Mirena. Okay? Does that make sense? All right. So we have a young student. She wants contraception. She has a new sexual partner. So which one, what would you choose? So we have 20, COCP 20, COCP 30. We have COCP and condoms or condoms alone. What would you choose? Why would you choose D?
The condoms prevent STIs in terms of pregnancies and
But what's the, I mean, would you prescribe everybody condoms and COCP? Would you prescribe both? What is the main reason in this scenario that we're telling her to take both? Okay, so when you're taking the pill for the first time, right? And you haven't taken you haven't taken 7 hormonal pills in a row yet, you're not protected, okay? So giving condoms in the first 7 days is important. So whenever you're starting somebody on new hormonal therapy, but they haven't yet taken at least 1 week course of the hormones itself, you need to give them condoms because they're not protected in those 7 days. So when you're first starting it, you need condoms. So yes, STIs is an important reason, but a more important reason is the fact that you're recently starting her on medication. All right. Now, the next thing is there's 2 options for COCP with different doses. In the normal question, what would we choose? 30. Okay, so 30 is usually the one we choose. In which situations would we choose 20? Yes, not being tolerated. So a lot of patients can get nausea and vomiting on the higher dose of COCP, and in that case, we'd give them on the lower dose. There are risks with putting people on the lower dose in that it has the same efficacy in terms of preventing pregnancies, but it has an increased risk of having bleeding and other of those adverse effects that you get with contraception. I don't know what the reason for that is. All right. Now, the last one is what's this used for?
the risk of bleeding and stuff.
Yeah.
Is that with a lower dose or higher?
With a lower dose. So increased adverse effects, but same level of efficacy.
Okay.
All right. Now, how about this one? The high dose levonorgestrel. What would you use that for?
Emergency.
Yes, emergency. All right, great. All right. Another very good question. Another very good example of why going through the exam papers, reading things like ETG, reading guidelines is going to help you a lot. All right. So before we go on, let's talk about cholesterol lowering medications. Okay. So decreasing cholesterol and decreasing triglycerides. So generally, what medications do we use? What's number 1? Statins. What's number 2? Yes, ezetimibe. And what's number 3? Now, in this case, this is not a first line, second line numbering. We'll talk about it. There's a lot of caveats with each of these medications. Yes, bile acids. So cholestyramine. Okay. And how about for triglycerides? Number 1? Fibrase. Number 2? Nicotinic acid. Number 3? Fish oil. Okay. Now we're going to talk about each of these. Again, I want to reiterate, this is not a first line, second line indicator. This numbering isn't 1, 2, 3. This is just numbering for the sake of numbering. Okay. So now we'll talk about each of these. Now, in this question, which one are the statins? These bottom 3, right? So how do we choose which statin to use? So which of these statins is first line? Yes. So in this case, now this is first line, second line. So that's first line. Okay. Simvastatin is second line. So when I say first line, second line, so simvastatin is used when you need, so if you need less than 35% reduction in LDL. Okay. So with rosuvastatin, if you need a greater than 35% reduction in LDL, you'd use rosuvastatin or atorvastatin. Okay. So those are your first line medications. If you don't need that much LDL reduction, then you use simvastatin. Pravastatin is okay. So pravastatin is right. So in cases where there's a risk of having drug interactions, which we'll talk about soon, then you use pravastatin. So if there's a risk of drug interaction, and there's another indication, but I've forgotten already. Okay, now, so statin. So with this list, each of these medications can either be used alone or they can be used together. All right, so statins are typically always first line for most lipid problems. So what's the biggest side effect that we worry about with statins? Rhabdo. Okay, and what's that secondary to? Myopathy, okay, due to myopathy. So being on a statin is one of your differentials for somebody presenting with proximal muscle weakness. Okay. And the other thing is that rosuvastatin, another reason rosuvastatin is first line is that it's not metabolized by the liver enzyme system, so the CYP450 system. So that's another reason that it's better. Okay. Now, how does ezetimibe work? Does anybody know? So this one decreases cholesterol absorption in the small intestine, so at the brush border. And that's usually used when you need an add-on therapy if the statin therapy is not working. Then the last one is cholestyramine. So this removes bile acids, removes bile acid from the enterohepatic circulation. All right. So there's a few cases in which case you cannot use cholestyramine. So it's completely contraindicated if the patient has hypertriglyceridemia because it actually increases triglycerides. All right. And the other thing is that it can cause drug interactions. So therefore, if it's causing drug interactions, which statin would we use? Pravastatin. All right. Now, fibrates. So what fibrates are there? There's two ones that you should know. Yes, Pheno. And another one is gemfibrozil. Okay. Now, gemfibrozil is important because if that is used with a statin, so if you plus that with a statin, that increases the likelihood of getting muscle toxicity. So that is something that you definitely can't use together. All right. Nicotinic acid is not really used these days. Okay. But that decreases the production of VLDL, which subsequently decreases the production of LDL. And the reason it's not used very much is because it's very poorly tolerated. Okay. So poorly tolerated. All right. Then the last one is fish oil. Now, fish oil is really important. So fish oil is first line when you're combining it with a fibrate. And the situation in which you would combine it with a fibrate is if you have very severe hypertriglyceridemia. So severe hypertriglyceridemia is more than 10. I don't know I can't remember what the units are, but if it's more than 10, you use fish oil as well. Now, what is the main risk for somebody who has very high triglycerides? What can they get? Pancreatitis, okay? So that increases your risk of pancreatitis. So that's in those situations, you would use fish oil. All right, so we've got a lot of writing on this page. All right, so this man, he's relatively old. He has high cholesterol. You started him on a statin, okay? And you started him on the maximum dose, which is 80. So we've talked about when the statin doesn't work, what do you give as well? Ezetimibe. So in this case, the answer is ezetimibe. All right. So this man, also relatively old, he just had pancreatitis. So based on that, what are we going to give him? So remember, fish oil, you use it with something else. Fenofibrate, okay? So only if the triglycerides were more than 10, you can still have pancreatitis, even if your triglycerides are not more than 10. In those situations, then we would use fish oil as well. All right. All right, so that finishes the GP section. All right, so now we're moving on to Psych. All right, see you later. All right. So first thing you see in this question, we have a relatively old man. He has a chronic history, okay, of these fixed beliefs. Now, what is fixed belief forms part of what definition? A delusion, okay? What's the definition of a delusion? Yes, okay? And it contradicts the cultural norms, okay? So he likely has some sort of delusion at the same time, which is maybe some sort of persecutory delusion. So he thinks he might be able to, and that's important. He might be able to see a camera and hear a whirring. So what would that indicate to you? Okay, so query hallucination. Now, there's a reason that I circled the might be. And the reason for that is hallucinations need to be very direct. They need to be absolutely certain. You need to, for somebody to have hallucinations, it needs to be something that they can describe for sure. It's something they know is coming from outside of their head. So they're absolutely certain that the hallucination is there. In this case, he's not sure. He thinks he might hear whirring. He thinks he might see a camera. If somebody did have a hallucination, they'd be able to tell you that it was a Sony camera that was 20 megapixels and the whirring was, 20 decibels loud. So that's what a hallucination would be. Now, the reason that's important is if he did have a hallucination, he would then meet the criteria for schizophrenia, okay? Given that he does not have hallucinations because he doesn't meet the definition, you can rule out schizophrenia. Okay. And the other thing is that stop him from living his life. With most psychotic conditions, it only becomes a problem and it only needs to become medicated once it starts having an effect on your life. So in this case, it's not affecting his life. So it's not going to be schizophrenia. What do you think is the diagnosis? So he has some kind of disorder that is predominantly due to delusions. So he has delusional disorder. Make sense? Okay. Now, before we go on, what is an autochthonous delusion? Yes. Why is that important? Nice. Why is that important? Okay, so this is something that we call a primary delusion. Now, usually a delusion has some sort of explanation, has some sort of cause. Okay, so when we talk about delusions, why do people get delusions? There's either some sort of genetic cause, there's some kind of underlying environmental cause. They might be on a drug. They might have some sort of impairment in their sensation. So, for example, people who have auditory problems, people who have visual problems, they are at risk of getting delusions. But a patient that has a primary delusion would have none of those. So it just suddenly come out of the blue and you cannot explain it. So that is an autochthonous delusion. All right. Anything else we need to explain? The rest of those should probably make sense. So this man, he says his internal organs are putrefied, therefore he has a nihilistic delusion. Okay? So nihilistic delusion relates to something that is going very wrong. Often it relates to your own body. You feel like you're dying or something very bad is happening. I can't remember the exact definition. Okay. All right. Now, I make another very important point with this question. First, we'll try and do the question. So I'm not going to give you any pointers. I want you guys to tell me what you think is the answer. I'm going to start with you guys. What do you think? Yeah, just answer. Everybody, please have an answer ready. Okay, what do you guys think? You guys? CT brain, what do you guys think? Drug screen? Roland? Shannon? Drug screen, and what do you guys think? Okay.
Also, I feel like both of these are wrong. I feel like that's your point.
And what do you think? Okay, so the answer to this question is urine drug screen, but I absolutely disagree. Okay, all right. Now I told you there's an important point with this. So last year on our exam, we had a question. I can't remember the exact stem, but in the end, the answer was implanon. We had that same question, at the very least, a very, very similar stem in one of the faculty release papers. On the faculty release paper, the answer was Depo-Provera. So everybody having that knowledge of what was on that past exam chose Depo-Provera on our exam. We subsequently got an email after the exam when the academic rep had a meeting with the faculty, and they explained why nearly everybody got that question wrong. So I stuck to my guns because I absolutely disagreed with Depo in the faculty exam. So out of spite, I chose implanon and I got it right. So no, they didn't. So that's the point I'm trying to make. Just because the faculty has released papers to you and just because they have released answers does not mean that evidence does not change, does not mean that guidelines do not change. So just because you see an answer on a past paper, do not take it for 100% correct, as people learned with that exact question. So for this one, what do you think is his diagnosis? See, he has a very clear diagnosis. There's no doubt about the diagnosis here. There's three criteria that he've met. The first one is an altered conscious state. The second one is, you tell me, what are the three main things here? Yes, respiratory depression and pinpoint pupils, okay? So, yeah, pinpoint pupils. So if you have each of these three things on the prompt guidelines, this increases your suspicion of having an opiate overdose. And in that case, what you need to do is do a therapeutic trial of naloxone. So that is the first line thing that you need to do. But this question is not asking that. This question is asking what is the most important investigation. So here, they've told us that the answer is urine drug screen. Now, I'll tell you that's what the faculty said, but I do not think that's correct. So urine drug screen, there's two ways that it happens. First one, you take a sample of urine, and you can get a result relatively quickly that will give you, a bit of a general idea of what's in the urine. The second thing you can do is send that off, and that's usually for some kind of legal proceeding, and that result will take a few days to come back. But the prompt guidelines directly tell you, as well as some, actually, I'm not sure if the prompt guidelines, I think it's maybe BMJ or something else. It tells you that getting a urine drug screen does not change your management, it does not change your treatment, right? So doing a urine drug screen here does not affect your management at all. So there's no point doing it. This is the point I'm trying to make. Now, you guys have said CT brain, which is completely reasonable. I can't give you a definitive answer, and a CT brain is very reasonable. It's very reasonable because this man has come up from the street, he's come with a altered conscious state, all right? And if he has altered conscious state, what you need to be afraid of is if he's had some kind of bleed or if he's had some kind of fall, something of that nature, you need to investigate it. However, this is asking you that most important investigation. No other investigations are ordered. And before doing a CT brain, there's a few things that you can do at the bedside. What are those things? Glucose is another one, but probably less important for this STEM. What is something else you can do at the bedside? You can do an ECG. Okay, why is an ECG important in opiate overdose? So a lot of drugs, especially amphetamines, they can cause a prolonged PR, okay? So if you have a prolonged PR, you can go into an arrhythmia. So an ECG is something that you can easily do at the bedside. The nurses will do that for you. So that's one thing, an ECG. CT brain, as we told you, is also really important. And the other one that's really important here, and is usually what I imagine would probably be the best answer, is a chest X-ray. The reason for that is that this is the biggest issue right now, the fact that he has respiratory depression. If a man comes into ED with respiratory depression, what is the first thing you need to do? Resuscitate him. What else do you need to do? Who do you need to call? What do you need to call? No. You need to call a code blue, right? You need to call a code blue. Who's going to come down in the code blue? What are they going to do? They're going to either at least consider intubating the patient. So in the patient that has respiratory depression, you need to ventilate them, okay? So what a chest X-ray can do for you is checking if they have non-cardiogenic pulmonary edema, okay? So pulmonary edema, and that's what it's used for. So I will tell you that on the BMJ best practice, that is the first line investigation to order. So the only point I'm trying to make in this question is that all the urine drug screening was suggested by the faculty, I don't think is correct. All right.
Do the chest X-ray before you intubate.
Intubate would be the first thing that you need to do, the very first thing. Okay, otherwise he's going to die because he's got respiratory depression. You don't know if he's going to deteriorate or not. Okay, so, all right. So, relatively old man, he's retired. So we know that he was smart in the past because he's a teacher. So he doesn't have some kind of underlying cognitive problem. He's got a 3-month history of some concentration problems, some memory problems, some energy problems, some irritability, so lack of interest in his family, which you would expect that he probably loves a lot. Okay, so he's had apathy and amotivation, and he has a decreasing mini mental. All right. Now, important about this is what is his scoring? Why is he getting a 25? because his recall and his calculation are low. That's important. Now, the first question I'm going to ask you is, what is the diagnosis? Why? Why isn't it something like dementia or a neurocognitive disorder? Good, you've made my point for me. Okay, so especially in elderly people and especially in depressed people, the reason that they score lower on the MMSE is due to the lack of energy. They can't be bothered to remember the numbers that you've repeated to them, which is why he's scoring a 1 out of 5. They don't want to do the calculation that you've asked of them, which is why he's scoring a 1 out of 3. It's not due to an underlying cognitive abnormality. He's a teacher and he's retired, so he evidently has good mental capacity. The other thing is that he's meeting all of the a lot of the criteria, enough of the criteria for depression. So the mnemonic that I use is same GCS, and then I just remember that having anhedonia and low mood are your major criteria. Okay, so S is for suicide, A is for appetite, M is for your motor, so your psychomotor retardation, E is for energy or emotions. I spelled that wrong. G is for guilt. C is for concentration. S is for sleep. Yes, sleep. Okay. So in this question, what does he have? He has decreased energy. Probably has a little bit of guilt. He has concentration problems. He's irritable, probably because he's not getting enough sleep. I'm stretching a little bit, but he definitely has a low mood, and he definitely has anhedonia. So he no longer has any interest in his family, so he definitely has anhedonia. So the best answer to this question is MDD. All right. Oh, crap. All right. So that's just a comparison between dementia and depression. All right, I'll try to go a bit faster. Okay. So bipolar. What medication do we give people with bipolar? Okay, so we give them mood stabilizers, correct? Okay, lithium. All right. What else? Say again? Okay. So another important piece of wisdom I want to give you is, again, buzzwords and getting correct information. Now, I know that in my own Y files, it says sodium valproate because I didn't check it up. But sodium valproate is not on the Australian therapeutic guidelines as being able to be used as prophylaxis in bipolar, okay? So you can't use sodium valproate as prophylaxis for bipolar disease. That's important. That's why you need to check up guidelines. You need to check things like ETG. The other reason that I bring this point up is we had an OSCE station last year on a patient that had bipolar and they're on lithium. And one of the questions was something along the lines of, what else would you give him, or what other management would you do? And a lot of people did very poorly on that station because I imagine they said sodium valproate. That patient had some renal problems, so they just instantly went to the second medication, which was sodium valproate. The better answer would have been something like aripiprazole or an second-generation antipsychotic. So sodium valproate is not something that you can use in Australia as prophylaxis. All right, but they are your classical mood stabilizers, so sodium valproate and carbamazepine. So again, this is why I'm reiterating, please read guidelines, please read ETG. Look at any question, see what the presenting complaint is. Let's say, for example, the patient is coming in with migraine. So type in migraine, RACGP guidelines and read it. So it might be an AFP article, but they're also usually really good. So lithium, what are the side effects of lithium? So all of them start with T, okay? So tremor, what else? Thyroid. So usually hyperthyroidism. Anything else? Oh, yeah, Yasmin said tremor. So it's usually a fine tremor. What else? You can cause anything else, guys? Say again? Is it? Okay. Teratogenic. Cool, I learned something. You can cause some thinking problems, so minor cognitive impairment. Okay. Okay. I don't know how to put that in. I will say tibial nerve. Okay. I didn't know that one. And thirst, okay? So these are your adverse effects of lithium. So adverse effects. They all come in thyroid. Okay? Now, if you have toxicity, the mnemonic is different. The mnemonic is gate. Okay? So does anyone know what G stands for? I think is it G actually upset? Might be. G, ataxia, impaired consciousness. I'm just going to write ACS, and a coarse tremor. Okay. So this is your toxicity symptoms. So that's for lithium. Now, how do you monitor lithium? Okay. So I'll start at 0 days. I'll start at, I'll say 3 months, and I'll say 12 months. Okay. So 0 days. So before you start lithium, what do? You check the renal function. What else do you check? TSH, exactly. Anything else you check? Yes. Why are you checking calcium? Yes, exactly. Parathyroid. So Roland brings up a really good point that it's not just hypothyroidism. It's also, you can also affect your parathyroid glands. Okay. So that's what you do before you start the medication. So this is actually 3 to 6 months. This is based on the RCGP guidelines. What do you do? And by the way, it might be a good idea in the OSCEs to specify what you mean by UEC. So you might also want to specify that this means like eGFR and that this means serum creatinine. Okay. So you might want to specify that clearly. Other 3 to 6 months? No. So you want to check lithium levels, and you also want to do a repeat UEC. And then at the 12 months, so annually, and also calcium. And annually, you're going to check the TSH. The reason for that is the thyroid changes very slowly. So there's no positive benefit from doing it quicker. Okay. So for this woman, she has tiredness, weight gain, and she's cold, which are all classical of hyperthyroidism. So you need to do TFTs. Okay. So J. Now sodium valproate. Maybe we'll do that on the next page. So the side effects for valproate is valproate. Okay. V stands for valproate. Okay. In color. Okay. No, I don't even remember. So I wrote it down. Okay. So increased appetite. Liver failure. Okay. So it's hepatotoxic. It can cause pancreatitis. It can cause. Sure. But it's also recorded, I think. I hope so. I hope no problem again. Reversible hair loss. It causes edema, causes ataxia. I'm just going to write decreased platelets, so thrombocytopenia, and can cause an encephalitis. So the encephalitis is particularly important. So this is because you have increased ammonia. So it causes a hyperammonemic encephalopathy. All right. All right. And we won't go into carbamazepine. Carbamazepine. The most important thing to remember about it is the egg granulocytosis, okay? So a lot of the C medications start with C, cause egg granulocytosis. All right. Now, this question is from a different exam. I won't tell you which, otherwise I'll get in trouble. Okay. So this man has CKD. He's on dialysis. He's previously been treated with antipsychotics. He's had some suicide attempts before, and now he's presenting with elevated mood. So select the most appropriate treatment. I haven't made this point yet, but please always read what's up here. So what medication are you going to give him? So first of all, what would you call his presenting complaint? Good, okay. So that's what I meant when I was saying don't follow buzzwords. Okay, buzzwords will not help you in the 4th year exams. I'm not trying to point you out. So bipolar disorder, a lot of people would have just fell on bipolar disorder and assumed that this was an acute, was just like the elevation in your bipolar. But better to call this is an acute manic episode. Okay. So what medication are you going to give him? Why? Good. Fantastic. I'm very happy you said that. All right. Where is it? Olanzapine. So olanzapine and risperidone are both first line for an acute manic episode. Now, the reason I put this question in here is on the student suggested answers, it said lithium. Okay. You can imagine why it said lithium, because somebody was using buzzwords and assuming that this was just the manic part of a bipolar disorder, but that is still not correct. So Yes. But the thing is, that's still okay. So another thing to point out is that you can use lithium in the short term, even if they have a renal impairment. It's when it becomes a long-term problem that you can't use lithium. The other thing is that generally we would only start a patient on lithium, even in the acute setting, if we had the intention of making that a chronic medication that we're going to use in the future, which we wouldn't if somebody has a renal impairment in the first place. So your normal mood stabilizers, your sodium valproate, your lithium, your carbamazepine, these are all second-line medications for acute mania. Your first-line medications are olanzapine or risperidone. All right. No, I can't promise that we're nearly done, but we are getting there very quickly. Hopefully it won't take too much longer. Okay, so I'm just going to shoot through these quickly. So we have a young lady, okay, she has lowered mood. So, okay, so essentially she has a little bit of depression or something. She has some panic attacks. And this is the important part. She compares herself unfavorably with her colleagues. This is important. Now, what would you guys say is the answer? I'll tell you the answer is CBT, okay? Now, CBT is a good answer. Now, the basis of CBT is that it assumes that maladaptive thoughts affect your behavior, okay? So in this case, she is having some anxiety, she's having some panic attacks because she has this paranoia that her colleagues are thinking about her. So what CBT aims to do is to get rid of this maladaptation. So that's what CBT is good for. So when the patient has some kind of cognitive process that is not correct, you'd use CBT. Okay, so we have an old man, okay? He has a chronic history of mood swings, amotivation, road rage, and that's not normal for him, okay? He has a lack of empathy towards his disabled grandson, all right? It's causing some strain on the family. What is the most likely diagnosis? So is it a stroke? Why not? Because it's a 2-year history, right? Is it hydrocephalus? No, none of the features. He's not depressed, okay? Does he have Alzheimer's? Alzheimer's, you need some kind of cognitive decline, which is not present in this question, okay? Does he have frontotemporal lobar degeneration? Potentially, okay? So we'll put that down here, maybe. Okay, does he have Lewy body disease? Okay, you need to have some kind of evidence of hallucinations to be diagnosed with Lewy body. So not Lewy body. Does he have vascular disease? No, because he needs some kind of stepwise decline. So we've established he doesn't have Alzheimer's. Is the normal? Well, yeah, who says he's not normal? Who are we to say he's not normal? Okay, normal pressure, no, again, he doesn't have a stroke. Okay, now frontotemporal dementia, there's 4, you need to meet at least, is it 2? I think you need to meet at least 2 of these criteria, okay? And I'll tell you what these criteria are. 1 is you need to have behavioral disinhibition, okay? Disinhibited, okay? That is because your frontal lobe is what affects your personality. So once you have changes to your frontal lobe, your behavior therefore changes. Second one is apathy / inertia. So inertia is when you have fixed beliefs that cannot be changed at all. So inertia is another presenting feature. Third one is lack of sympathy, okay? So he doesn't have any sympathy. The fourth one is having stereotypical behavior. Okay, stereotypical behavior. And then the last one is hyperorality, okay? So eating a lot, eating lots. So let's check if he has these or not, all right? Does he have apathy? Yes. Does he have no sympathy? Yes. Has he already met the criteria? Yes. So the answer is frontal temporal. So you need more than 2, greater than 2 out of 5, all right? Okay, again, this is a question, please don't get buzzed. Now, what the reasons you might get buzzed is, I reckon maybe because of this. So we have a 59-year-old, 3-week history, difficulty with handwriting. Does anybody know what we call that? Yep. So she has dysgraphia. Okay. She has topographical disorientation. Okay, so this is a symptomatology by itself. but this can one either result from a stroke, so result from stroke, or second one is a continuation of some other kind of chronic illness, one of those being hemispatial neglect. Okay, so hemispatial neglect, or other chronic things like Alzheimer's. Okay, so maybe she has hemispatial neglect. She has a problem dressing. What do we call that? Dressing apraxia. Okay, clumsy. I don't know what you call it. You call clumsy, I guess. Okay, she has a risk factors. So we'll call this a risk factor. Therefore, what does she have? Okay, does she have a frontal lobe stroke? Express some personality changes. Hydrocephalus? No, she's not depressed. She doesn't. Does she have Alzheimer's? No. So way too fast. 3 weeks. It's acute. Okay, so she doesn't have any of these things. Does she have vascular dementia? Maybe. Okay, does she have Alzheimer's? Okay, is she normal? We're so judgy. Okay, it's not MPH. Does she have a parietal lobe stroke? Does she have a temporal lobe stroke? No. Okay, possibly. All right. So this is your brain, and this is the kind of syndromes that you can get. Okay. So complete MCA. Does she have hemiplegia? No. So we can completely rule out that. Does she have a partial M1 syndrome? She hasn't had any kind of lacuna symptoms, so no. Does she have a weakness of a hand or arm? Maybe. Does she have an aphasia? No. So we can rule out that. So does she have right-left disorientation? She's clumsy, so possibly, maybe. Does she have dysgraphia? Yes. Okay, so she has that. Does she have acalculia? Maybe, probably. So I'm going to write it anyway. Okay, she maybe has that. Okay, does she have a dressing apraxia? We don't know if she has that. Does she have spatial neglect? Likely. Okay. Does she have constructional apraxia? Maybe. Okay. So the thing is that she's meeting conditions for most of this. To have something called a neurocognitive disorder, especially vascular disease, there needs to be evidence of some kind of stepwise decline. In this case, we've only got one symptom. We've only got one position in the timeline. So it's much more likely that she's had a parietal lobe stroke than anything else. So that refers to vascular dementia, which is its own syndrome. Have a look in the. You look it up. Just because I'm very aware that it's nearly 8 o'clock for you guys. Okay, so 19-year-old, and again, I know I'm skipping over this, but it's always important to read what's up the top. So young man, he's being bullied at school before, so he did distance education, as said. He has no friends. He's found it really hard at Monash. He feels very anxious even when he's on PTV. He can't go to S1. He doesn't make eye contact with the lecturers. He can't answer if anyone speaks. What does this man sound like to you? He doesn't sound like a social. He just sounds like a shy kid, right? There's no disorder in this question. Okay, there's no evidence of anxiety. Well, they're like anxiety, but people use anxiety very loosely. There's no evidence of panic attacks. There's no evidence of avoidance. The thing is that if you have social phobia, you need to have avoidance of things like public transport, which he doesn't have. So there's no psychiatric abnormality in this question. What he does have is maladaptive thinking. He has maladaptive cognition. His maladaptation is that I was bullied at school. People weren't nice to me, so people will always not be nice to me. So we need to change the maladaptation that affects the behavior. So in this case, his behavior is missing public transport, not interacting with people. So we need to get rid of that. So therefore, what does he need? He needs CBT.
So I had a question. With all the options that I've said, when would you use with group therapy?
Alcoholics.
Is that first line?
Yep. Okay. Well, like it depends on how the alcohol is presenting. For chronic management, yes.
Okay, yeah.
Okay. So Fahima, she's 18. This is the important word, okay? People got very caught up on this question. She just received a scholarship to study overseas. Is she going on the plane right now? Okay. If Monash told me I got a scholarship, are they going to tell me to jump on the plane the next day? No. Okay. So she's never flown on a plane before, so she's very anxious about it. And so she's very anxious about going on the plane. So the question that people were arguing about was, does she need this or does she need, yes, there it is. Which one does she need? Desensitization. She's not going on the plane right now. She has a specific phobia, so that's what's important. She has a specific phobia. If she was going on the plane tomorrow, then yes, oxazepam might be reasonable because that's a short-acting benzodiazepine. In which case would we use temazepam? Yes, insomnia. Okay, but again, it's not first line. That's going to be important soon. All right. All right, so this I'm just going to skip over this because it's quite simple. Okay, so what do you guys think about this question? So we have an insomniac, okay? And she's always ruminating. She's very anxious about things, so she worries a lot. She's wondering if a sleeping tablet will help. All right. So what do you think we should do? Do you think we should give her agamelotine, which is atypical, or I'm not even sure if atypical, does she need cognitive therapy or CBT? Yeah, maybe. She does have some maladaptive cognition that's affecting her behavior. Okay. Discuss principles of sleep hygiene. Maybe. Does she need insight-oriented psychotherapy? No. Usually for like people who've been abused. Diazepam? Absolutely not. So I'm just going to do that. Okay. I don't even know what modafinil is. Zolpidem? Okay, so definitely not. Okay, would we give Zolpidem? Yes, maybe. So maybe. Okay, refer to sleep physician. No, not yet. Relaxation therapy, maybe. Okay. So the answer to this question requires you to have read the ETG article. Okay. So the answer here is sleep hygiene. So any of these answers, so CBT is a good answer. Zolpidem is not a good answer because that is always non-pharmacological first. So that's not a good answer. And relaxation therapy is also a good answer. So there's three potentials here. The reason that is sleep hygiene is because when you read the ETG guideline, when you read the RCGP guidelines, discussions about sleep hygiene is always first. So that's why sleep hygiene comes first. All right. So confusion, so old, confusion over 6 months, difficulty walking, and falls, and incontinent. So, yes, walk, weird, and wet. Why did I write this? This is the MPH triad, okay? So she's had difficulty walking, she's been confused, and she's incontinent. So this is normal pressure hydrocephalus. Okay, again, another simple question, so I'll skip over it. This is just a classical presentation. She's young, so therefore you give her fluoxetine. Oh, sorry, wrong question. Oh no, right question. Okay, again, just for the sake of time, your family, so she has some family problems, so therefore you need to do family therapy. So do you guys remember Cassia Asa, how about that? You remember that girl? So in those kind of people who have some kind of, sort of defined disorders, equine therapy can be very useful for them. So she's an example of somebody who went through equine therapy. I'm not sure why or how it works, but it's very effective. Yeah, it's literally horse therapy. So like you go to like horse ranches or places that have horses, like they're very set programs, and like you do something there and you become a better person somehow. Okay, but apparently it works very well.
It sounds like education.
Okay, so like in this question, she was having family difficulties. She's blaming herself, and she has a lot of problems. Family therapy is an obvious answer. So the better thing to discuss here is what's the difference between this and this. Okay, but how would you describe it?
It's not the family that's dysfunctional.
Yes. Okay. Exactly. So you're using the family as support. So as Paul correctly said, especially important in things like eating disorders, anorexia nervosa. Family therapy is where you're trying to fix relationships in the family, as the problem is in this case. Okay. All right. Okay. So we have a middle-aged female. She's living in her home and she's caring for her aging parents. That's an important word. And another important point I make is usually there's a reason everything is in the stem. So in this case, she likes to be, well, she doesn't necessarily like to be around people, but she can at least tolerate being around people. So it's unlikely she's going to have a schizoid personality disorder. Okay, so she's been brought into the ED by her neighbor, another very important point. So she slipped on the driveway, and so she slipped, and she claimed that it was because her neighbor had been emptying some leaves. So she probably has slipped on some leaves, but she thinks it was her neighbor who put it there. If the neighbor was out to get her, would the neighbor have brought her to the ED? Okay. So, and she thinks that they've tried to annoy her for 22 years. So leaving their bin outside, talking loudly, etc., etc. So what do you think is this patient's problem? Do you think she's got a subdural? Delirious? No, well, probably not. Okay, frontotemporal? No. Do you think she's got Lewy body? No. MPH? Do you think she has paranoid personality disorder? Okay, so for a personality disorder to be diagnosed, you need to have evidence that those personality traits were present from at least adolescence or early adulthood. So in this case, she's at the very least, at least on the borderline. Okay, so potential. Schizoaffective disorder. She has no evidence of any mood incongruence. Okay, she doesn't have schizophrenia. She has no, well, I know one might argue that she might be having like auditory or some kind of sensory hallucinations. She might be having delusions, but you know, it's not very convincing. Okay, so I'll put a question mark here. Schizotypal personality disorder. Maybe, okay, maybe. Substance induced, no. Temporal lobe, okay. So I don't think it's schizophrenia. There's no clear hallucinations. There's no clear delusions. What she's most worried about is that people are out to get her, okay? Which makes in this question the most likely answer being paranoid personality disorder, okay? This one was a bit more of a hard one and a bit more of a stretch. All right. Okay. Again, a simple question. So this lady has been taking increasing doses of citalopram. What's the problem with that? Yes, okay. Now what Paul said is not incorrect, but there's a few things we need to learn about serotonin syndrome. So if she has long QT, what are you going to do? ECG. All right. All right. Now, I want guys read this question carefully. Anybody have an answer? Does anybody know? What do you think, Yasmin?
It's fasting.
Why?
She's got diabetes.
Yeah. So I remember talking to the person who wrote this question last year, and we were in the tutorial, and we were asking her a few questions, and we we're asking her about this question and why this was the answer. And she read through it, and then it clicked to her that this question was, and she was like, wow, whoever wrote that question did a really good job. And then we looked back and it was her who wrote the question. So in this question, what we have, so we have a middle-aged female, she's got intellectual disability, 30-year history of schizophrenia, so she's on olanzapine. What's the main problem with olanzapine? Yes, metabolic. So it's pro-diabetogenic, metabolic. All right. Now she's becoming more lethargic, disruptive, and she's taking other people's food. So she's got polyphagia. Drink. So she's got polydipsia. And she's got polyuria. Okay. Lethargy is likely just hyperglycemia. So therefore, she needs a fasting blood glucose. I'm not sure. I think there were a lot of answers for this question.
Right, what's the intellectual disability that's really
Throw you off.
everything that for a reason, right?
I guess
It is.
She just takes people.
I mean, the thing with intellectual disability, it explains why she's being incontinent of urine and why she's having these behavioral abnormalities. Otherwise, the question would be too obvious, right?
I think it's a pretty good question. Like, it's realistic because I don't know. I just
It
find
is.
psych and on the ward when you go out to see like other patients, you see a lot of people with like long-standing mental illness. Like, and everyone seems to think that like whatever problem they've got now comes back to the mental illness, but it's actually just like
Yeah, like you need to think outside of the box as well.
Yeah.
So polysubstance abuse, non-compliance, underweight, clubbing, erythema, gynecomastia. He has cirrhosis. So you need to do LFTs. Nearly done, guys. Okay. All right. So, oops. So we have a man. He's going to have a colonoscopy. All right. He's feeling anxious about the procedure. Again, another important word. He's not feeling anxious that he might have bowel cancer. He's feeling anxious that he's going to have a colonoscopy. What do you give him? Okay. In my opinion, the answer should be this, to be honest. But yes, oxazepam is the best option, the most appropriate from the list. I honestly do not think you need to give this man anything. You really shouldn't. But oxazepam is a short-acting benzodiazepine, which should help him with preoperative anxiety, which is what. So if you were, remember, if you were to make a presenting complaint for each question, this would be preoperative anxiety or perioperative. Okay. Now the other thing is you might consider doing psychoeducation. Okay. The problem here is that psychoeducation, the aims of psychoeducation is to try and increase health literacy, and is to try and to increase what's the word when you try like stay on that medication? Compliance. Yeah. So those are the two aims of psychoeducation. And in this case, he's not feeling anxious about his disease, he's feeling anxious about the procedure. Okay, what do you guys think this man has? Some bipolar, confusion, tremor, nausea, lithium. Okay, so remember we talked about toxicity and we said gait. Okay, so GIT, ataxia, ACS, altered conscious state, and tremor. Okay, so does he have these? He has tremor, he has altered conscious state, he has GIT upset. So he's got that, he's got that, he's got that. So he definitely has lithium toxicity. All right. All right. So Paul, I'll give this question to you. Why? Yes. Well, okay, good logic. Okay. The why now why? So this is a very important learning point. Okay. So medications, so SSRI by itself, yes, there is potential that it can give you serotonin syndrome. However, the most common cause of serotonin syndrome is when you have two serotonergic medications together. Okay. So one serotonergic medication and another serotonergic medication that are given together. So for example, if I give somebody amphetamines, so this increases the release of serotonin. If I give someone tramadol, this decreases reuptake of serotonin. If I give someone St. John's wort, that also causes something with serotonin. I can't remember what. Okay, so all of these together can precipitate serotonin syndrome. The best way to remember serotonin syndrome compared to NMS is that it causes everything to go up. So he's hyperreflexic, he's sweaty, so he has more PNS activation, he's confused. So this man has serotonin syndrome. I'm sure it's probably there. There, all right. All right. Now it's very important, again, another good learning point, read up the management for these, okay? The biggest management you need to do is you need to stabilize the patient. For any critically unwell patient, the first answer is always stabilization. So if the patient needs ventilation, you need to ventilate them. Then comes all of your symptomatic management. All right. All right. So
Is pethidine teratogenic?
yes,
Is it just all opioids? Or just...
typically, well, I'm not sure. Actually, I'm not sure about that. I don't know. Okay, 32-year-old woman. She's disorganized. She abuses substances apparently. She's shouting, so she's had some change to her behavior. Her housemate says she's been taking pills, dilated pupils, quite confused. What do you think is the answer? Yeah, look, the answer here is actually anticholinergic delirium, which also fits her symptoms, but I thought that was a very difficult answer to get at because drug overdose is also reasonable because amphetamines can also cause dilated pupils. So that's a question you need to sort of research more. This is classical. Yeah, clozapine. So clozapine, the reason it causes that is it is a direct agonist of the M4 receptor, which is the muscarinic receptor, and that is responsible for salivation. All right. So we have a 50-year-old man, chronic schizophrenia, living in a hostel. So he's independent with activities of daily living. Symptoms are currently under control. He administers them himself, so he's got a lot of insight into his condition. His siblings have got the inheritance. He wants to go on a holiday with a carer. So again, he has a lot of insight. So who should decide if he can use his inheritance for his holiday or not? Himself. Okay. So guys, that's the first 50 questions. We'll do the next 50 questions. I'm kidding. Okay. So that's the end. So keep. So I hope that was helpful. Stop. Okay. See you everyone.